Hi, everybody. How's it going? I think we're about to begin. Really excited to have you all here. Thanks for coming out tonight. And thank you very much to Mercy West Hospital, along with the CEO, Michael Kramer, the man without whom none of this would have happened. I am Cliff Ransom. I am the Executive Editor, Americas, for Scientific American's Custom Media Group. We're a division separate from editorial that works with commercial partners to develop events such as these around important topics. Tonight, working with Braeburn Pharmaceuticals, a fantastic, small, innovative company, we put together really an all-star cast of panelists to talk about a subject that I think sadly is near and dear to this audience's heart, which is the opioid addiction epidemic. Obviously, this is a difficult issue for many of you, and you all know it very well, I'm sure. But I think that it's such a big issue that certain facts bear restating. For example, since 1999, the number of opioid-related deaths has quadrupled in this country, and that makes them more numerous than auto fatalities. And that sort of scrambles the brain when you think about it, that this problem came out of nowhere and now is such an epidemic. And I know I'm preaching to the choir here because here we are in Ohio. You guys are ranked, sadly, number 2 in the nation for opioid-related deaths. And your corner here in Cincinnati, in southwestern Ohio, has been particularly hard hit, and I know you know that. Cincinnati, the surrounding counties, have some of the highest rates of opioid-related overdoses in the nation, and that's precisely why we're here tonight. You guys know full well that addiction is a really complex syndrome. It ties together physiology, psychology, it ties together social issues, regulatory issues, healthcare infrastructure, education, all that stuff. And tonight, our goal as a group is not to sort of, tear our hair and talk about why this problem has come to pass. I think that ground has been pretty well covered. Our goal tonight is to talk about solutions to this problem. Our goal tonight is to detangle all of those elements and try to present to you a continuum of care. It's led by medication, supported by therapy, supported by policy changes, access, and ultimately to present to you, hopefully, a vision of a complete solution that will bring some relief to the addicted, the families of the addicted, and to those who treat the addicted. So in that spirit, we've gathered a really fantastic group here tonight. These folks really comprise a who's who of addiction medicine. I'm very excited for our discussion. We're going to talk amongst ourselves for a while. Towards the end of the discussion, we'll pass a mic around. If you guys want to ask questions then, by all means do. So file the questions away, please. But before we do that, I'm going to introduce our esteemed panelists one by one. They all have such long resumes that I hope you don't mind me reading off my notes. Immediately to my left is Behshad Sheldon. She is the President and Chief Executive Officer of Braeburn Pharmaceuticals, where she is working to bring to market long-term treatments for opioid dependence, schizophrenia, and pain. Behshad has spent the past 25 years working for leading pharmaceutical companies and leading pharmaceutical companies. Millions of people have benefited from the drugs that she has helped bring to market, including Glucophage, Plavix, Abilify. Did I say that right, Behshad? Abilify, sorry. Yep, there you are. In May, Braeburn Pharmaceuticals, led by Behshad, received approval for the first long-acting buprenorphine implant. It's designed to treat opioid dependence for up to 6 months. It's called Probufene, and I guarantee you'll be hearing more about it in the months to come. So that's Behshad. Welcome. Thank you. Next to her, we have Dr. Andrea Grubb Barthwell. She is currently the director at Two Dreams Outer Banks, which is a comprehensive wellness center for the treatment of alcoholism and substance use disorders. She is also the chief medical officer of the Manor, Madison, Wisconsin, and the founder and chief executive officer of EM Global, which is a Washington, D.C.-based healthcare and policy consulting firm. She has spent her career looking for solutions to substance abuse disorders. She served as the deputy director for demand reduction in the Office of National Drug Control Policy under President George W. Bush. She is a past president of the American Society of Addiction Medicine, and she was a recipient of the Betty Ford Award in 2003. She has a very long resume, and if you can imagine, I did condense that. So next to her, we have our hometown candidate, Shawn Ryan. Shawn is a dual board certified emergency physician as well as an addiction specialist. He's currently an assistant professor in the Department of Emergency Medicine at the University of Cincinnati, and he's president and CMO of Brightview Addiction Treatment, which is a Mercy Health affiliate. So I'm sure some of you know Shawn here in the audience. We're really happy to have him here tonight. He completed his residency in emergency medicine at the University of Cincinnati, along with his MBA at the nearby Lindler School of Business. He has been a leader for many initiatives right here at Mercy Health, including the prescription drug abuse epidemic and post-acute care collaboration. And he was recently elected as the president of the Ohio State chapter of the American Society of Addiction Medicine. So, last but certainly not least, on the end, we've got David Sheff, who is the author of not one, but two separate New York Times best-selling books. His first one was A Beautiful Boy, A Father's Journey Through His Son's Addiction. He followed that up with Clean, Overcoming Addiction and Ending America's Greatest Tragedy. David is roundly regarded as an expert in addiction. He was named by Time magazine as one of their 100 most influential people in 2009. He's won numerous awards, including the College of Problems on Drug Dependence, and he was just announced to win, I think it's okay to say this, the Media Award by the American Society of Addiction Medicine. So congratulations in advance. If you're still not convinced, he's even got a shout out from Sanjay Gupta on his page where he says, as a journalist, as an author, as a journalist, as a father, as a chronicler of addiction, David is without peer. So that is our group. Thank you all for being here. I hope you're as, you in the audience are as impressed as I am. So group, I would like to open this discussion up with a broad, universal question for you all. As I said, tonight, we're going to talk about solutions. And in light of introducing yourselves, I'd like to know, starting with you, Behshad, what are you doing today, right now, to stem the tide of the opioid epidemic?
Thank you. It's an honor to be here. It's an honor to be with everyone here on the panel. When I started Braeburn Pharmaceuticals about 4 years ago, it was to launch a new innovative solution for opioid addiction. I thought, okay, I've done this before. It's relatively, straightforward. I've worked in areas where there's a lot of stigma. Certainly with Abilify, I saw the worst, I thought, of how we treat people with schizophrenia, with mental diseases. They end up on the street, they end up in jail. I thought, okay, I understand this. And I thought, well, is this really as big a deal, or is it because I'm in this field that I seem to see it everywhere? And then it started to become clear that it really is everywhere. And very shortly thereafter, we had a tragic incident in our own family. We lost someone to addiction. And then just less than a year ago, went to the funeral of the son of another friend when his mom got up and said, "My beautiful boy was born in 1991." And we all cried for the next hour. That's when my oldest son was born. So it became very clear that, number one, the epidemic is everywhere and it's real. And that, number two, the stigma that I thought I knew about with every chronic disease. We all think, people with diabetes, well, if they just only ate better, people who have heart disease, if they just exercised more. So there's stigma with lots of other therapeutic areas and lots of other diseases. But this one is different. This is different because there's even stigma in having medicine and taking medicine and being medically treated. So for us, we have a kind of, our dogma is like we hold these truths to be self-evident at Braeburn. Addiction is not a moral failing. It is a chronic brain disease like any other chronic disease. It requires long-term outpatient treatment. The number one goal is to keep people alive. Number two is to keep them functioning and part of society and having custody of their kids, having jobs. And yes, of course, to not be using. But number one, to keep them alive. And it's easy to say that we hold these truths to be self-evident, but they're obviously not self-evident to everyone. That's why we're all here. They're self-evident to everyone in this panel. I'm sure they're self-evident to everyone in the audience, but they're not. This is not self-evident stuff to the people out there. In society, there is still this impression that if only people who have opioid addiction or any addiction, if they wanted to, they could just pull themselves up by their bootstraps and stop using, and they'd be fine. And why should anyone invest in this field? This is the question that I had to answer to the venture capitalists that ultimately backed Braeburn. Why should we invest in this field? And my answer was, look at how there are 140 antihypertensives. There are hundreds of cardiovascular diseases. There are probably 1,000 molecules in investigation for cancer. There are dozens of antidepressants and antipsychotics. We have 3 medicines to treat opioid addiction. And we don't use them very well, or to the extent that they could be used. So the argument was that this is such an underserved population that how could we not go here? And how could we not invest in this space? But it's really kind of an uphill battle, and we're still working every day. We don't have any, we're not naive. All we hope to do is make a small dent in what is a terrible problem. We're trying to approach it both from the standpoint of bringing solutions to treat opioid addiction with long-acting implantables and injectables, a weekly, monthly, and a 6-month buprenorphine implant. And then also to approach it from the pain side by investigating these same products for pain. So imagine when somebody goes to an urgent care and they've blown out their knee, instead of walking away with a month's worth of oxy, they get a shot that lasts a week. And they're told, okay, if you're still in pain, come back and we'll see what, but there is no, there's no adding to the pill burden out there in the world. Similarly, you have an operation, you get a shot beforehand, you wake up, you're not in pain, you don't get morphine, you don't get pills to go home. So we're trying to come at it from both of these perspectives. Having been a novice to this field, everything I know about addiction medicine, so if I say anything wrong, you can put the blame in the right place. Everything I know about addiction medicine I've learned from Dr. Andrea Barthwell, to whom I am eternally grateful, and to many of her colleagues. And so I think I'll just turn it over to the experts now to talk about the medical parts of this.
Thank you.
Sir, Dr. Barthwell, what are you doing right now?
What am I doing? Well, thank you, Behshad. It's really been a trip, a journey that we've been on, and your time in it at Braeburn sort of mirrors my career that starts back in the early 1980s. And what we knew about opioid dependence then, heroin addiction, was about 0.5% of people in the United States developed a problem. They were mostly young men. They were fairly homogeneous as a population. And in the late 90s, the Office of National Drug Control Policy, where I later served, started trying to determine whether those numbers were holding, because there seemed to be a shift that was happening. And some aspects of treatment alternatives to street crimes or ask the government to try to get a better handle on those numbers, and we started seeing those numbers creep up. And we now know that a much more significant proportion of our population are exposed, and are exposed at a very early age. And they're exposed sometimes for medical or quasi-medical reasons, but many are exposed through sharing of medications with someone that they know and trust. And we learned, as we did in looking at people coming back from Vietnam, that the set and setting of use could predict whether there were going to be issues associated with it. People's genetics determined whether there were going to be issues associated with the use or the exposure. The drugs themselves had predictors of whether there would be problematic use or dependence developing from exposure. And what we've seen is that the numbers have continued to increase. The other thing that parallels your history and mine is that you're trying to address the stigma. And you've done so much to help us with bringing medications to the market that were used broadly by people. But one of the things I think you've learned is that even the people who are trying to help people with this disorder are stigmatized. I'm going to probably hear from my colleague here to my left in a minute about that, and about how it's difficult then to have an adequate workforce to deal with these problems. And even when regulatory agencies think about responding to these issues, there's a concern that if we put medications on the market, that they have to be controlled or walled off in certain ways that makes access difficult, because there's a fear that an unscrupulous physician will get involved with writing prescriptions for people who have this disorder, and the next thing you know, we're going to have pill mills. And so the controls that are even on the solutions make it difficult for people to access and further stigmatize. But what I do today is work with my laboratory on the Outer Banks, where I try to find solutions for people who have this disorder. And we work in a very deep way that a lot of the programs that work with individuals with this disorder can't work. We work with both psychosocial therapies and medicine when needed. We have the luxury of being able to use medicine in treatment, and some addiction treatment programs can't. They have rules that make it impossible for someone to be on a medicine for a heroin addiction and be in treatment at the same time, so that they can either get treatment with medicines or get the psychosocial therapies, but they can't get both. That's a problem that we need to overcome, and I'm trying to overcome it with a very small population of people, and to figure out how we work with folks who are comfortable with psychosocial therapies and abstinence-based therapies, how to get them more comfortable with understanding that medication-assisted recovery is important. And we need people like your company making a commitment to bring more medications to the market. I also treat people in my office, and in fact, a large part of my career has been in working with individuals with opioid dependence, both in methadone treatment centers and in the office-based setting, and some of the early publications around office-based opioid therapy, even with changing the regulatory environment of methadone. Those early publications I wrote in that area, because I believe that if we can normalize the treatment, the people can have their lives normalized and can return to a fuller functioning back in their community. That we shouldn't be walling people off so that they can get treatment for this disorder. And then finally, I think the thing that I'm most challenged with today is the notion that we are in a race to get to these young people who have this early exposure and then switch to heroin from prescription drugs. We're in a race to get to them before they get to the undertaker. That people in my company, people in my life, people in this industry talk about being in a race to get to these kids before they get to the undertaker. And it's all about trying to save lives. And while communities have geared up to have Narcan available, that's an emergency room response, an emergency response in the community. But we have to talk about what happens next after you reverse someone's overdose and they leave the hospital in withdrawal, or they leave their basement. If their mom has some in their medicine cabinet, they leave their basement in withdrawal. What do we think is going to happen next if we don't have a more definitive response to that overdose? So those are the areas that I'm working on. I'm also trying to use some of the connections that I made with my service in Washington to change the regulatory environment that we all work in so that you can do more in your community. So I think with that, I'm going to stop.
Thank you, Andrea. So what am I doing today? I think the thing I do every day is educate. That's other professionals. I'm very pleased to see many of my colleagues here in the audience, so many physicians who are engaged in the community, both inside of Mercy Health and outside. And so we try every day to educate the public on the disease state. I was having a discussion with a colleague at the AMA the other day. We're releasing a paper here in a few months about some payment models and some issues with the disease. And he said, why does the preamble have so much discussion about why this is a disease? Don't we all agree? And I said, no, Harold, you and I agree, and probably most of the people in this room agree, but we still have a huge component of the population that does not. And so we have a long way to go to convince people that we have a disease state that requires neurochemical intervention. And so the second part of what I'm doing on the education front is talking about what treatment is. We have a huge disparity of the understanding of what treatment is. And we have a lot of people coming out and telling you what it is. I feel blessed that I'm on the stage with someone that the two of us could probably win that argument 99.9% of the time. But the answer is treatment is three things. It's the medical treatment, the psychological treatment, and the social support. It is a biopsychosocial disease. And it has to be all of those things for all people. I don't care if they're the most functional alcoholic attorney or the most dysfunctional heroin addict living under a bridge. It is all of those things that every one of our patients need. And so we have to educate on what is treatment, and it is not yelling at someone in a church basement enough for them to stop. It is not. I think that I'm excited to educate people about the developing state of medicine and what we're doing. I get to talk to multitude of physicians and hear pretty regularly as I look around the room about the things that are coming out. We send each other articles. Look at this, man. We're going to have better stuff. We're going to have newer things. We're going to have this tool in our toolbox to deal with this better than we can today, and that excites me to educate others about those potential. I agree with Behshad. It is bizarre to me that my armamentarium is so limited. I talked to my cardiovascular colleagues, and they're choosing from the latest and greatest antiplatelet medication, which costs who knows how much to develop and deliver, et cetera, but those patients will do better because of those developments. They will. Our patients do better. The other thing that I do, I run a treatment organization, and we see hundreds of patients at all times, and there's a lot of our staff here in the audience, and we work hard. We work hard to stop them from getting to the undertaker. And what I'd like to see in the future state is stopping them before they're ever even near the undertaker. I want to see the teenager who had too many Percocet because of too many knee surgeries, et cetera. We know that story, and the young athlete. I want to see that guy before he ever gets to the point where I'm trying to rescue him from heroin. That's what I want to do in the future state. And we're starting to get there as we work on educating the public on the stigma, which I think is, if I were to describe one issue that is the most substantial, that is it. There is stigma among the treatment professionals. I know that however many years ago when we started, I've been working with Mercy for a long time. When we started this discussion years ago, I don't think many of the Mercy employees that I see in the room would have been nearly as educated on the topic as they are today. And I think that was stigma. I don't want to deal with that. It's those people over there. And it's not. As Behshad said, it's not to those people over there. We'll probably ask David in a minute. And so that stigma permeates the entire industry, and the whole problem is, a lot of the problem is based on that. Fearful to seek care. I was in a discussion yesterday, or 2 days ago, And one of the individuals said, why do they leave the emergency departments when they go there? Isn't there help there? Not today, there's not. And that is really unfortunate. And they're stigmatized against, and I think one of the moms at this event 2 days ago said, just so you know, the patient stigmatizes themselves worse than you ever can. They beat themselves up worse than you ever could, no matter what environment they're in. So please understand that there's also that. And I think that's the biggest barrier. Like Behshad said, she probably has dealt with conversations in the pharmaceutical industry she never would have about any other drug. Maybe Abilify was related, but probably not as bad.
Like this,
The stigma is probably not as bad. And I think if we're to overcome anything, and something I work on is talking about that. And I, like everyone, have been personally affected by this. And understanding and coming from that perspective, we just got to talk about it. We got to talk about it more. I'm glad you all are here, and I appreciate your attendance.
I'm glad I'm here, honored to be here, and in a room with people who are our hope, really, people who do understand that this is a disease and that it's treatable, and you're at the cutting edge of this, and we need to make sure that other people are educated. In fact, everyone in this field is educated. When I'm up here listening to the three of you, I was thinking that I spent 10 years, my eldest son became addicted to every drug you can name when he was a teenager. And we spent 10 years trying to save his life. And he made it, but there were a half dozen times when he came this close to dying. And I was thinking that if he was in emergency rooms 4 times. I got calls from doctors. Doctor said, Mr. Sheff, you have to get down here. We have your son. He's not going to make it for the next hour. Another doctor called to tell me that they thought they were going to have to amputate his arm because it had become infected from shooting drugs. Another overdose. In those emergency rooms, they first of all treated him, and when I made it down there, his father, as if we were pariahs. Pushed to the side. Doctors, I heard a doctor say, he's just a junkie, and we've got people who are really sick here. And then when he sort of patched up whatever got him in there at the first place, an overdose or the accident or whatever it was, he was sent out without maybe the suggestion that he go to an AA meeting, and not even that usually. No transition from that crisis when someone is so vulnerable to go into treatment when it's the most short-sighted thing that we could be doing, because we know that for every $1 that we put into early treatment, we save $7 in the long run. And instead what happens is, as happened with my son, it's a revolving door. So if there were 10 years ago an emergency room where Nick could have wandered into and been funneled into real treatment, into a treatment system, and where he would have got psychosocial stuff, he would have got attention to the therapy he needed. One of the treatment centers, he had been by then diagnosed with bipolar disorder, and he was on bipolar medications, and one of the treatment centers he went into, their first order of business was take him off his bipolar medication, which was the one thing that was keeping him from jumping off the Golden Gate Bridge. And then the other piece was, so Nick, this was 10 years. Nick would go into treatment, he would relapse, he would do well for a while. We would be just beside ourselves with hope, and then it would be dashed over and over again. And every time he relapsed, when he was doing well, he relapsed once again because he was never getting the care that he needed. And that is actually why I reached out to Behshad when I read about the product that she's putting out, because here was a kid who finally, after many years, after going through programs where we asked about medications, I'd read about medications, and the heads of these programs and the head doctors even were saying to me, we don't believe in medications. You don't treat drug problems with drugs. What I now know is that if he had been treated with drugs, with the right drugs, the times that he relapsed, he would have been protected. Because he would relapse, he'd be on a medication, he was on buprenorphine, he was on Suboxone for month after month after month, and then he would get depressed. He would stop taking his medication, and he would relapse. Or one time he traveled across out of the country, and he ran out of his medication, and he relapsed. The idea that you could protect someone for a week at a time, a month at a time, and even 6 months at a time, to me is a breakthrough. I have to think that if I had you on my team 10 years ago when Nick was in trouble, we wouldn't have gone through what we went through for all those years. The other thing I thought I would do is, we all talk about the statistics. We read them in the newspapers every day, the horrific statistics in Ohio. The fact that now addiction and addiction-related problems is the number 3 killer in the country after cancer and heart disease. Right now, excuse me, we have a child in this country dying every 19 minutes because of opioid overdose. So we talk about these numbers, and the numbers are dramatic and they're horrifying, but with these numbers, and even when we talk about the medical part of this, about this disease, and we talk about treatment, we can forget about why we're here talking about this in the first place. And because I wrote these books about addiction, and this was a world in which people were suffering, their children were suffering, their husbands, their wives, people in their families, and because of the stigma, they hid. They didn't tell people in their next cubicle at work. They didn't tell their neighbors. In some cases, they didn't even tell other people in their families. Don't say anything because the aunts and uncles are going to be here, because of the great shame that comes with this disease that doesn't come with any other disease like this one, because again, it feels like this is a choice in some people's minds. Why don't they just stop? They must be a terrible, immoral person to choose to do what they do to themselves and to their families. I heard from so many people, and when the books came out, and it was just a relief for people to hear someone talking about it. I'm not alone. It's not anything magic I did with the writing. It was just that somebody was up there, a dad was up there saying, this is what happened to our family. We were blindsided. We thought it could never happen to us, and it was hell. So I wrote about it, and that's when I realized that it wasn't just our hell. I realized how pervasive it is, how it's ubiquitous. Everybody knows somebody, if they themselves are not dealing with a problem with drugs and alcohol. Someone in the immediate family or someone close to them. The letters I get, I brought a few just because I get them every day, and they always stun me. And they do take these numbers and this challenge that professionals have to treat this disease. It brings it right to the core. And it's the core of people, and it's the core of the suffering that people all around us are experiencing. I'll just read a few. I could read them all day. My son was addicted to prescription medications. At 21, he was introduced to heroin. 2 years later, heroin took his life. I found him in the bathroom in respiratory arrest. I started CPR until the paramedics arrived and transported him to the hospital. He was on life support for 5 weeks. He passed away in July. Some days the pain is so unbearable that I don't think I can make it. Another father wrote, he told me about his 20-year-old daughter. For the last 4 years, she was using marijuana and drinking. Then someone gave her OxyContin. She was at an Ivy League school. She had good friends, friends she loved. After her 3rd rehab, she was clean for 6 months, but then she relapsed. Someone gave her more pills. They left her, her friends, her supposed friends, left her on the sidewalk outside of a hospital. By the time they found her, she was dead. A mother described her son as the latest sacrificial lamb. Drunk and stoned, he was killed in a head-on collision. Another mother wrote, we knew she smoked a little marijuana, but that was the extent of it as far as we knew. The coroner said there was heroin in her system. She went from the most loving child to someone I didn't recognize, and then I lost her. My 19-year-old daughter died last month, a father wrote. I loved her with every ounce of me. The world lost an angel. A mom, my precious son died of a drug overdose 8 months ago. He was 24 years old. He got addicted to OxyContin when he was 15. He couldn't afford it anymore. He started using heroin. He hated being an addict. She sent pictures of her son, and 2 of his friends. And she wrote, "All 3 of the boys in this photograph are dead to overdoses. First Ben, then Jackson, then Josh." As I said, I could keep reading on and on. I'll just read one more. To show how bad the treatment system is, to show how hard it is for people to get good treatment, a friend of mine is one of the most renowned addiction doctors in the world. Many of you know him, Tom McClellan. When I was in trouble, I tracked him down. He was a big help to me. But he told this story. "I was the addiction expert," he said, "but I didn't know what to do when my 2 sons became addicted. I asked my colleagues, they're experts too, and they didn't know what to do. Groping his way through the dark, desperate to help his sons, Tom did everything he could. He had access to the best care possible, but it wasn't good enough. One of his sons now is in recovery, but his younger son died of an overdose." I will stop talking and see what, Cliff, you'd like us to talk about next.
Wow, that was a really, thank you for that, everybody, and thank you particularly, David. That was a really moving moment to hear directly from parents. I think that, you know, when you gather a group like this with so many different perspectives, and then it comes out that you all sort of zero in on the same issues, you know, this problem of stigma and all of the implications, the cascading effects that stigmatization has on everything from, you know, a family dynamic to, you know, FDA approval processes. I think that the idea of using medication is something that we're definitely going to touch on. But that idea of stigmatization and bringing it around to sort of a human level, that's really powerful. So thanks for that. I want to kind of follow up on that because, Shawn, when you and I were talking earlier, we were talking about how do you fix that stigmatization problem? If you guys zeroed in on this as an issue, we're talking about solutions this evening. So what do you do?
I mean, first, understanding how long we've stigmatized mental illness and substance use is not since the 70s, right? So there's a little bit of a frame of reference problem. We've done a bad job of this since we were people. We've done a bad job of treating substance use disorders since we were humans. We've also used substances inappropriately since we were. So trying to get a broader understanding of that stigma, I think, is necessary first. What is it rooted in? Why does it exist? I think that's where you start. And then you realize how long the road's going to be. If we're not in this for the long haul, both for the treatment of substance use disorder as well as alleviating some of, it will never be none. Come to that realization, it will never be no stigma. But we better understand how long the haul is, I think, is part of it. Again, get your mind wrapped around the fact that not only is this epidemic probably not going away anytime soon, very unfortunately, I really hope I'm wrong. I think Dr. Barthwell probably hopes she's wrong about that, but reality is probably not going away anytime soon. So I think understanding the scope of the stigma, why it exists, and then working on it. Humanizing and understanding and talking about it in public forum is one way. And then, of course, as I spoke on education earlier, we need to start with education young, in the medical professions especially. Thank goodness the medical schools are starting to talk about not only the use disorder, but the associated, basically gap of treatment for mental illness and addiction, so that more professionals will want to go into it, understand it, and deal with it.
Andrea, I'd love to have your sort of perspective here too, as somebody who's worked at a high level in policy. You can pull a lot of different levers, but how do you shift public opinion?
So I think that in order to shift public opinion, you have to describe people who are affected by a problem. You have to humanize it and personalize it. And unfortunately, we're in the midst of a crisis now where it is being personalized, very personal to all of us. Because I was at a funeral 4 months ago of a young man who had completed a treatment episode, and the recommendation was to continue on with medication therapy. But there were pressures, a lot of pressure for him to see if he could do it without. And he relapsed and died. And that happens. That happens just way too often. And the people who get to make these decisions and put this pressure on someone who has the disease are generally people who are very close to them, people who would not think to suggest what the nature of the care should be if it were another disorder. I had a person come to our office for a very sophisticated, comprehensive workup, and they saw a addiction psychiatrist, an addiction physician, and a counselor and a psychologist. And at the end of the workup, when we presented our recommendation, he said, you know, I talked to my uncle last night, and he's in recovery through AA, and he thinks I can make it in AA. Now, they had different disorders, completely different disorders. And my response was, if you had gone to a cardiologist and had, you know, a cath and seen a variety of professionals in that office, you wouldn't have called your uncle who had a heart attack to figure out what your next move is. You'd listen to the professionals, but there's just so much that is upside down about this, and it's going to take some time to fix it. So we've got to personalize it, describe the problem, start describing solutions, and then we've got to have the funding to do what we need to do with those solutions. And you know, we've got to have medications, and you know, we've got to have our policymakers recognize what they need to do to enable, support, nurture the development of solutions, and to recognize that this is something that we as a country have to work on. I think that will begin to help.
Well, I agree with you there, and that's, you know, that gives us a great sort of broad platform to dive into some of the specifics. One of the specifics that all of you have brought up is the use of medication and how we use medication to treat a long-term disease. And, you know, Behshad, I'd love to sort of come to you for your perspective. How are we using medications today, and do you think that it's appropriate?
So right now, 1 in 5 opioid-dependent patients are getting buprenorphine, which is widely seen as the gold standard. There are lots of reasons for that. Stigma, of course, is probably the #1 answer. There are cost and insurance issues. We were looking just to see, you know, what does the world look like before we introduce our own product, at some medical coverage policies, for example, of insurance companies across the country. And there were things in there like, doctor, before, you know, in order to get this prior authorization approved, please indicate your taper plan. When are you going to take the patient off this medicine before we give you the okay to start them on this medicine? And I thought, okay, well, I don't think anybody ever did that for my Lipitor. Nobody said to my cardiologist, when are you going to take her off her Lipitor before I can actually let you start to put her on it? It's a really strange situation. But it comes from a place, again, of not understanding that there are genetic predispositions combined with environmental factors that have resulted in this disease that is no more overcomable simply by will or simply by behavioral modification than a high cholesterol or diabetes. You tell everyone diet and exercise when you put them on glucophage or on Lipitor, but you know it's not going to work. I mean, people pretty much, doctors will hand out the prescription at the same time as saying, I'm supposed to tell you to try diet and exercise for 3 months first, but here's your prescription, because it's unlikely to work by itself. You need the combination. Of course, you should do everything together that you can. We're asked all the time, because, you know, we have this interesting new innovation, which is 6 months of treatment. have you thought about using this for tapering off? Maybe, the next cycle it can be, do a study that shows the next cycle you can do fewer, or you can let this go longer and taper people. And my response is, knowing that only 15% of patients who come off buprenorphine can stay relapse-free, I don't want the other 85% on my conscience. I understand some people want to get off medication. Some people want to get off it feels good to not be on meds, right? We all want to say we are well. We all want to take lower doses of everything. Like some of my best friends in pharma refuse to take Tylenol for headache. Like, why? Just, but that's how we all are. We don't want to take medicine if we don't, somehow it makes us feel better not to take medicine. But this is one that is life-saving. This is the most unforgiving disease. In this hour, 3 people have died, and probably because their brain receptors were wiped clean in some sort of Narcan intervention, or maybe they were in rehab and therefore they didn't have access and they weren't using, they lost their tolerance, and they went back and they used the same 5 bags that would barely get them high, and now they're dead. And my question for these guys is always, and I know the answer because nobody wants to say the word use, but my question is always, why don't you just tell people, if you slip up, if you fall down, just use less. Just use less, and at least you'll be alive. But I guess nobody wants to say the word use.
Brian, I'd like to sort of pick it up with you, if you could. I mean, thank you, Behshad, for that perspective. Ryan, you're coming at it from sort of the entirely different side, the emergency medicine side, the response side, and also, a treatment center side. So where do medications fit for you today, and where would you like them to fit in the future?
I think where emergency medicine is on this right now is in the life-saving piece. They're involved in the revival with Narcan, naloxone. They are undereducated and under-resourced in engaging people in treatment. And that is 2 things. That is a very frustrating position for an emergency physician to be in who is trained in life-saving. And they literally are looking at individuals who need life-saving and they do this. And it is not to their fault, right? They were never trained in school. They're not supplied with the resources by the industry. The hospital and health system situation is not built to allow them to perform treatment or engage patients in treatment today. And so as I do walk that line, my hope is to be able to develop a system of care, David and I were talking about, where a patient is in that portal potentially desiring to be engaged in treatment and is given treatment or at least plugged in immediately to treatment by the emergency medical physician. That is a tall order, just to be clear. It is going to take a long time and lots of funding to develop that system. I liken it to the cardiac care system in the 1960s. If you had a heart attack in the 1960s and you showed up in the hospital, you had a 30% chance of dying off the bat. If you made it to the other side of that 30%, you would be given maybe 1 or 2 medications, heparin, morphine, aspirin, maybe, 2 of the 3, and that was it. And now if you are in the emergency department or even anywhere near it that they can get to with a helicopter, you will get a pre-hospital EKG in the helicopter sent directly to the cardiologist by conference. They will review it, and you will be in the cath lab getting a extraordinarily life-saving, complicated, and expensive procedure within minutes. My hope is to see that development of system of care for addiction treatment. This is as, if not more life-threatening, especially in the younger population, than cardiac disease in the United States today, period. And so that's where I hope to see it go, realizing the huge lift that's going to be on all of us to do so. And I really do hope that Narcan becomes less of an issue. That's what I think as an emergency physician, I would really be very happy, and I'm sure all of my EMS colleagues would be extraordinarily happy to see less Narcan, and that's not happening anytime soon, but less Narcan as a part of the solution.
Don't you think that the best thing that's happened in cardiology isn't just a big expensive procedure, but what happens after? People are now sent home on half a dozen different meds. They get a beta blocker, they get an ACE inhibitor, they get aspirin, right?
Cardiac rehab, engagement with a specialist.
But they don't just get sent off like good luck.
No, it would be considered complete malpractice to do so.
Exactly.
Would
And
be
yet this is
considered-
what we do with people who show up in your ERs and are revived with Narcan, and then they just, bye.
You might get a period of hours, at least in the hospital, while you're waiting for serial enzymes. And what we see happen with people who show up after a Narcan challenge is what happened with Prince. You get a report sometime in the next week that something's happened. Or what happened to a young lady that showed up in an emergency room in my hometown of Chicago. She was given a slip to go see a treatment provider 48 hours later. She never got there. She died in that intervening 48 hours. They leave the hospital in withdrawal. And there's this thing that we struggle with as a society. We know that drug use is a preventable behavior. And we understand that addiction is a fundamentally treatable disease of the brain, but whenever we think about addiction, we think about the use, which is a voluntary behavior for someone who doesn't have the disease. So we bring that knowledge about it being a preventable behavior forward, and we want that person to just exercise free will, to choose not to use when they've lost their ability to choose not to use. And certainly when you send somebody out in withdrawal, they have very few options. And they have learned through hundreds of thousands of trials what to do when in withdrawal or nearing withdrawal, and that's to use. And you've uncovered all the receptors and you send them out in withdrawal. What do you think is going to happen in the next 2 hours? If not to find and to get the drug, use the drug, and maybe recover from the use of the drug if you don't die from the use of the drug.
And to be very clear, that it is like I said, the most frustrating feeling as an emergency physician to be in that place. And it is not, there's no blame laying there because that physician or groups of physicians cannot develop an entire system of care, right? If there was no cardiologist and all the things Behshad described and the medications and the continuation and the engagement and all that other stuff in the cardiac rehab, emergency physician would be the same place they were in 1960. Hey man, you might want to take that aspirin, you're probably going to die anyways. And that's where we're at today. And I guarantee you the emergency physician that day was not like, this is awesome. I can't wait to tell this guy he's got a 1 in 3 chance.
I have a quick question to ask. We've mentioned here that medication is a problem. Shawn, you said that you felt like you didn't have much of an arsenal to work with. David, kind of coming to you for a high-level perspective, why don't we have much of an arsenal to work with when it comes to medications? What's holding us back? Why aren't we in the same situation that we are with cardiology drugs?
Well, first of all, we do have medication that works, and if patients could get it, all these kids wouldn't be dying. If they were put on either from the emergency room, even if the hospital couldn't treat, but referred to a physician who could prescribe, get them on Suboxone, whatever it would be, right away, and then continue follow-up. So there are medications that work. But we are in this field, I think everybody knows this, we are probably 30, 40 years behind where we could be and should be. I think it's always interesting to know that in 1970, it was President Nixon who launched the war on drugs. And very quickly, the war on drugs became part of a war against drug users, against children. He also launched the war on cancer. And cancer, of course, was treated like a disease. So we have, 4 decades since then of money for research. We have access to treatment. You don't just go to a cancer doctor or a cancer center. You go to a certain specific kind of cancer center, depending on what kind of cancer you have. So there's a lot of catching up to do. And the big piece, of course, is money, because money is limited. It's really hard from the researchers that I know. They are fighting for very small grants. But there are so many good ideas. There's so many people that, with the resources, we could make up for the last 40 years fairly quickly. And of course, we should be, because we can't wait.
Behshad, I want to kick it to you as well. You mentioned that there's a pipeline issue. You said that there's hundreds of drugs, if not maybe 1,000 for cancer in the works. When I looked at the listings, I saw that addiction medicines were listed as NA, not applicable. Why is that? And I mean, if we're saying, geez, medications would help, why aren't there more?
I think it goes back to the stigma that we've been talking about. There are some new promising mechanisms of action. We've actually started to work with both Hopkins and NIDA, National Institute for Drug Abuse, to bring a couple of their compounds, very early compounds in, to try and develop something that is totally different, not an agonist, not an antagonist. So try and get at it from a different mechanism. But for to be slightly capitalistic about it, even though I'm personally, as my friends know, lean quite left. If a drug company doesn't think that there is going to be any revenue, then they're not going to go into that and spend hundreds of millions of dollars developing a product. If they don't think insurance companies are going to pay for it, they're not going to do it. We've taken this leap that we're going to be able to do well by doing good, and we're testing that proposition. We're going to see how it goes with this suite of products that hopefully will be able to take someone without ever having to take, except for maybe one test dose of a buprenorphine pill, all the way from early to late stages on medications that guarantee that they're getting blood levels of buprenorphine. But we have to have access, patients have to have access to doctors. You have 33,000 physicians who are allowed or data waived, and they're allowed to use buprenorphine, and only 6,000 of them really see adequate number of patients and have gone to the 100 patient limit, and now maybe hopefully will be going up to 275. So there's many doctors that just say, not in my practice, don't want those people. I spent a day in Pittsburgh with anesthesiology, addiction medicine physician, Dr. Kunkel, and saw 24 patients that day. And not a one of them you wouldn't sit and have coffee with. They were decent people like everybody in this room. This is not something that could happen to anyone. It does happen to everyone. But then you have people who say, why should we pay for medicines for them? Why should we put investment into this kind of field? And that's why there is not more than what we have now. But if only buprenorphine was used more, methadone was used more, naltrexone was used more, we would all still not be quite in this horrible pickle. We would be in a lot better position. But even the 3 medicines we have aren't adequately used, and that has a lot to do with funding. I think finally Congress came to the conclusion that this is not a red or blue issue, this is a purple issue, and so they finally passed the CARA Act that said, let's raise these limits, let's allow nurse practitioners and PAs to prescribe buprenorphine, and no money. No money came with this beautiful act that was passed. And in the beginning of this whole really long-seeming election cycle, I was so encouraged because I thought this was going to be in front and center in the national conversation, because Jeb Bush was talking about it, Chris Christie was talking about it, Governor Kasich was talking about it, Hillary Clinton was talking about it, because she went to New Hampshire and all anybody talked about with her was how their children were dying of overdoses. And yet then it all kind of got usurped by craziness. And now I have to say, I think President Obama has come a long way. I mean, he came and sat at the ARC summit and said the words disease of opioid addiction. That was actually a momentous occasion for our field. And he's actually put forth even in the HHS, raising of the cap and dollars being allocated to treatment. And I think now, there is one candidate who has a very comprehensive plan, and there is one candidate who came to Ohio and said that it's all going to be fixed because he's going to build a wall. So I'm hoping that, however we end up with this election, that people realize that they have to put their money where their mouth is. They have to fund this disease like the deadly epidemic that it is.
I was going to add only that we also have to, we keep going back to stigma because so much of what exists out there is related to stigma. But man, we have to figure out a way to separate good treatment from bad treatment. I read a statistic that it's a little old, so hopefully it's changed a little bit, but 80% of the treatment programs in this country they're based on an old model, the 12 steps. Nobody's knocking the 12 steps. They help a lot of people, but we know that we have a disease here, and it involves brain chemistry, it involves biology, and we know that people need more than praying. They need more than turning their life over to a higher power, because we know how to treat these people, and yet 80% of the places that these people go, patients will never see a psychiatrist. They won't be diagnosed. They won't be assessed to see if they have co-occurring psychological disorders, and most of them do. They're told to pray. They're told to go to meetings. Sometimes they go to groups. Sometimes they're told to go to 5 meetings a day. I went to a lecture in Los Angeles about addiction psychiatrists were giving a lecture on medications and what we have now and what's coming down the pike. And a guy stood up, and he was the director of one of the biggest programs in Los Angeles, one of the ones we read about, the ones where movie stars go in Malibu. And he was aggressive. He was yelling at her and saying, "You psychiatrists are trying to take this away from us, essentially. This is a problem of morals. It's a problem of our spirits. It's a problem," I forget the word he used. It's about there is no place for medications. We want to keep psychiatrists out of this. And they use the word disease, but they don't treat it as a disease. And it's huge. And I don't know how. Well, one of the ways we go there is that we keep having failures. So when I get letters from parents who have sent their kids to 10 programs and they've had the same treatment, no treatment, I tell them what they should be looking for, and they were like, "What? You mean I don't have to keep my kid on the street and wait till he hits bottom?" And which is what everybody else is telling me. Go to see a doctor, go to see a psychiatrist, go to see someone who knows about addiction medications, because that's the first line of defense if your child is on opioids, if anybody is on opioids. And suddenly there's a light. And it helps the stigma too, because when people are funneled into a treatment system that's based in the medical world, we treat diseases in the medical world. And so it's part of a cycle that hopefully is changing, but needs to change faster.
Well, that was a wonderful segue to sort of the next topic I wanted to address, because obviously we can talk about medications, we can talk about the broader issue of stigma, but really we're here to try to define that continuum of care, and Shawn, you mentioned that earlier. Access to treatment is such a huge part of that. Dr. Barthwell, I'd love to get your perspective on what we're doing right when it comes to treatment today and what we're not doing enough of in terms of access.
And I'm going to thank you for the question. I'm going to try to get at it by closing up the loop on some of the things that have been said already that aren't sitting well with me, that I need to address. We were talking about treating cancer, and what comes to mind is that there's a cancer registry, and we pool all of our information, and we figure out with a lot of precision the kind of cancer that you have and what medications are available or what clinical trials you might be eligible for if you burn through the medications that are available, and we use a lot of precision to try to figure out what kind of treatment is going to help you. And we talk about, an opioid use disorder or a substance use disorder or nicotine use disorder as if it's the drug that's the disorder, but it's an addiction. But it's not monolithic. And we have medications for some, and we don't have medications for others, but not everybody needs the same thing. And we have to be able to do some sort of competent assessment to determine what is the best response. And if we're getting these kinds of results that we're seeing with buprenorphine and there's an opioid use disorder, we've got to use it. We can't let our own biases or beliefs interfere with a person getting the kind of treatment that's going to keep them alive or help them to thrive or help them restore themselves to as near as makes no difference normal. And we don't do that. This 1950s treatment system that we have in this country that we expose people to, where in some of the larger providers, you're not even called a patient, you're called a student. I have a son born in 1991 who is a student, and I'm not expecting my health care insurance to pay for his education. But we put these people in places where they're in auditoriums and they're learning about the disease, and they're not even referred to as patients or clients. We don't recognize that there is a disease that they're treating. We're actually trying to educate them about the disease, that it exists. And usually the standard around which we educate is alcohol, and then we try to teach them how that disease has expressed itself in them. And then they have a seed of hope planted that they can go forth and work the remedy in the church basement. But we don't use everything else that we know works, applied in a comprehensive way, as you referred to. So there's access, and there's issues with our, Obama and this administration through the availability of the Affordable Care Act has increased access tremendously into addiction treatment services, the addiction treatment enterprise, that may or may not at all be connected with addiction medicine, but it's allowed more access into the addiction treatment enterprise, and that's a start. So that gets more people eligible. Every day across the country, somebody who's trying to get into treatment is told by an admissions officer, go out and buy a policy, keep yourself alive for 30 days, and then come back after your waiting period and we can get you some treatment. And in fact, there is even competition. There are people who are fighting to get that policy. They'll fly you in if you will use your policy with them. So there's all kinds of stuff that's going on within the addiction treatment enterprise. But when you get there, you're a student, you're not a patient. And you're learning, and you're made responsible for working all this stuff up yourself. So there's the access with reimbursement, there's access into appropriate care, and then there's the need to create the access where addiction medicine and the addiction treatment enterprise are married. And then there's the whole issue of access. What do we do with these doctors who got the waiver to write buprenorphine but are not? And sometimes we hear those people, and we talk about them as if they've done something wrong. There are doctors that got the waiver so they could treat people in their practice, but they don't want to run a practice around that. And so they're going to have small numbers. And then there are other doctors who want a practice of that. And they should be able to have larger numbers. And there are emergency room physicians who are seeing people, and they should be able to do something there that may not be permanent, but at least keeps that person alive until that person and their family are mobilized enough to figure out what that person actually needs. And then that should be tied to, a medical evaluation and a psychosocial evaluation to determine what's going to give them the best outcomes. And then the American Society of Addiction Medicine has a campaign where they're trying to raise money now to create a registry. So we, through our dues, are paying for a registry, not the National Institute of Health. Why isn't NIH doing that? Why are we trying to put our dues to this so that we can improve care? There are all these inequities that have to be addressed.
We're getting a little tight on time, but I want to come back to you, Shawn, just to sort of cap it off, and maybe David, you can add to it at the very end. This continuum, right? Somebody shows up in acute care, then moves, hopefully, to a treatment center, and then hopefully moves out into the community, back into their family and their community. How do we string this together?
The good news is, although it feels like we might have to invent the wheel, it's not the case. We have other chronic relapsing diseases that we treat that are extraordinarily aligned with what we're dealing with today. So we just need to look at those, recognize the comprehensive, ridiculous plans we've made around them sometimes, and then enact it. It's way harder than it sounds to say, of course.
Devil's in the details, yeah.
Yeah, devil's in the details. But let's just take a fairly simple look at the chronic diseases we treat today. And again, you don't wait until a diabetic's legs come off prior to treating them the first time. That's insane, of course. If I said that, hey, I saw this diabetic for the first time, I didn't do anything until his legs fell off, you'd be like, I don't want to practice next to you, get away from me, right? You would never treat anyone like that. So we need to look at those other chronic relapsing diseases, define that continuum, and then work on it. And I have a colleague in the back here who I work with quite often that works with the insurance industry, and we talk about it. We both know how heavy that lift is going to be, but it's not that we don't know what to do. That is a fallacy that people are spreading. We do know what to do. We're not doing it. And we have to have some key policymakers, insurance programs, communities, hospital systems decide to do it. That's what we have to do.
I guess the only thing I'd add is that it's an acknowledgement of the complexity of this disease, and it doesn't, using diabetes as a good example because it is chronic. And so as much as we can look to other diseases that are treated successfully, there is a continuum here. If someone is in a crisis, they do probably end up in the emergency room. They may have to be revived with Narcan. Then they need, if somebody's going to die, they need the most intensive treatment we can get them. Then they need follow-up care. And this is something that there's no trade-off, or there's very often, there's a word for it, a trade-off from an intensive primary care to a next stage care, to an intensive outpatient program. But even then, someone might wean off that. They go to a program for 5 days a week, and then 4 days, 3 days, 2 days. This isn't going away, and so there have been, why couldn't, like we do with other diseases, if somebody has cancer, and it's very critical, we treat them, we bring them into the hospital. When they're doing better, we send them home. Hopefully they'll be better for a while, but if it comes back, if there are signs it's going to come back, they come back to the doctor. There may be a process in which they'll come see their doctor at first every 3 months. Then if they're doing well, maybe every 6 months. There should be a similar follow-up in this world. There's no reason why an addict, once he's out of treatment or she's out of treatment, shouldn't come back and see their doctor every 3 months at first, just to see how they're doing, check on medication. Maybe after a couple of years, it would be appropriate to go down to every 6 months. Again, I think it's changing. I think that we all agree that it's such a big problem. It's so overwhelming sometimes. It feels like it's hopeless, but it's not hopeless. I mean, what we're hearing about now is that there are a lot of options. We certainly have options that we didn't have 10 years ago. And so, at the end, I have to feel hopeful, but I'm impatient. I want it to happen quicker.
Well, thank you for leaving us on that note of hope. We have gotten a little tight on time, but we do have the opportunity to ask a couple questions. Somebody's going to be marching around with a microphone. Don't be shy. Questions? Questions? There it is, the icebreaker. Nice work.
Thank you for the panel. It was very informative. There was a photograph taken in Ohio of 2 parents overdosing and a child in the back, which gained national attention, probably had a lot of views. How do you raise awareness for the general public without stigmatizing it? So, in other words, in the way that you want to portray the patients?
I think you show people in recovery is how you raise awareness. I think that there was a lot of articles written about that picture. One of the most profound was by an MIT professor. It was amazing how he destroyed the individuals who decided to depict that as the disease state. That is the most critical form of the disease state, right? It is not the person. When you show a diabetic, you don't show them in a diabetic ketoacidotic coma in the ICU, right? You show the person who's getting treatment in their primary care office. You show the person who's getting, none of the diabetes pharmaceutical commercials show people in a coma, do they? It's ridiculous.
Happy smiling people.
Right, happy smiling people. So I think you show people in recovery. And I think that does a lot of things to move the stigma, to show people it can get better. I think that's the answer.
Yeah, I think that also requires funding, a lot of PR, but in the right way. PR that continues to message that this is a disease, that there are ways, hopefully, to even prevent it by the same way we have little children in kindergarten do PE. There should be some resiliency building brain exercises right from the beginning, so you can start to, make them able to deal with all the stresses of the world. So there's the prevention end of things. There's showing people who are doing well, who are living normal lives, taking care of their children and not having their children hover over them as they've, met an unfortunate situation. So, one of the things that we're planning on doing is just continuing to have conversations. I've been talking to reporters for like a year and a half, and I think that things have changed. I hear very different questions now than I did a year and a half ago. The first thing that people say now is, yeah, I understand it's a disease. I understand there's very few solutions. What do you guys have going on? Do you have a solution coming? Whereas it used to be, tell me again, why is it that you think it's a disease? So I think some progress has been made, but we need to keep pushing. We all need to keep talking about it. Talk about it at every cocktail party you go to. People need to realize that this is not something that should be surrounded with shame and stigma, but something that we should all talk about the way that we now talk very easily about anxiety and depression and bipolar. Like, this is a disease like any one of those, and we should just talk about it.
And also, I guess I'll add very quickly that all these things lead to another piece, which is that we can prevent this disease, and we can also interrupt it at a very early stage if we're thinking about this differently. And so if we have pediatricians, general doctors trained right now, another statistic, I've got all these statistics in my brain, but this one, they did a study that showed that about 10%, only 10% of pediatricians were able to recognize a drug problem in their patient. We bring our kids to our pediatricians to help us raise our kids healthily. If a doctor at that level could recognize someone with a drug problem, send them to a counselor, there are brief interventions. If someone has not progressed, they can do a 3-session counseling session that's been shown to nip it in the bud. And what happens then is it's a cycle, because then we're stopping people from going to the level where they're losing their children, they're passing out in the car with their children, they're breaking in, they're robbing. Part of the reason, of course, the stigma is there, because addicts at the most extreme level, when they aren't treated early, they do stuff that is horrifying to them and to us. And so the earlier they're treated, the more we will prevent that, and there's a cycle then, too, of the stigma going away.
I think we have time for one more question, if you guys are game for it. Yep. Thank you.
You had mentioned that we know what to do, we know what's needed. How do you see us getting to that point that we actually have the continuum of care that is needed? What can advocates do? What can parents do? What can families do? What can professionals in the field do? How do we get to that point that we get what we need?
I think it's recognizing that we do have a path forward, and then getting the education on what that is. So I say we know. I would probably should say some of us know. It's a better phrase. And then, depending on your life's role, if you're a physician, an educator, an insurance provider, policy writer, you think about how do you drive towards that goal, all of us. In all honesty, some of the issues with hospitals and health systems engaging in this continuum is the community doesn't support it. So if you're just an advocate in the community, going to your hospital board or your community board and saying, hey, look, we have some of these pieces that I understand should be in place, but they're not. Why not? And so, I mean, some of the community centers we've put in as an organization, we fully recognized the stigma we were going to deal with in the community and did our best to deal with that. And so, in your if a solid, well-organized treatment company comes to a community, they should be supported. That's that part of the continuum that has to be engaged. So I think the answer is recognize what we need to do. Again, learn more about that. I say it easily, but it's not going to be easy. And then I don't want to focus on the funding piece, but if you think we bought a continuum of care, if you think we built a continuum of care for cardiology for anything less than $1 trillion, you didn't go to math class. I mean, it cost us 50 years and billions to trillions of dollars to do that. I hope we don't have that timeline or that expenditure on this issue, but it's not going to be a couple of bucks or 2 years. And then we just have to recognize that.
Yeah, I think there's also redirecting some funding, because while some patients clearly need some amount of time in a residential rehab kind of place that costs, I don't know, $30,000, $40,000 a stint, that could pay for an entire year's worth of outpatient treatment that is probably more appropriate for the vast majority of patients. And we've just grown up, I forget who said it, the 50s kind of model, but that's treatment. That's not treatment, guys. That's not treatment.
It's a vacation.
Maybe it's a spa stay. It's not treatment. We don't send people out to the country to take in fresh air anymore for lung diseases, for tuberculosis anymore. It's time to redirect funding to what actually has been demonstrated by clinical evidence to work. And we have plenty of that. Not enough, but plenty still to make a difference.
And to recognize across the life of that treatment, people have different requirements, because you can see there's a move to give people more buprenorphine, but people are saying, but only if it's within this comprehensive counseling modality. But at 5 years, many times people are able to maintain the gains from treatment that they've made in a self-directed way. So we are very prescriptive when it comes to talking about what people need for this, and we don't allow the models to develop that make good sense, and that an assessment drives the matching. Because 40 years of studies in this area has shown us that some treatment is better than none, and more is better than less, but treatment is best when it's driven by assessment, buttressed with case management, and completed with follow-up care in the community. Not everybody needs the same thing. We should do an assessment like we do for other disorders and determine what the severity of that disorder is and the intensity of services that are going to bring about the changes that can be maintained now at a lower level of care. All too often, there are other factors that determine. We try to do the lower level of care first so we can get a failure to justify a higher level of care. We don't use the assessment to determine to start at a higher level of care. So I don't think that we're advocating that you eliminate anything in the continuum that's needed, but that we use good sense in matching people to what they need, what an individual who's presenting needs.
I want to thank you for asking such a great question. That was sort of the perfect way to sum up all of the things we were talking about. There's been so much said on this issue, and I think it's hard to break new ground, but I do think that we did break some tonight. More money, more doctors, more medications, more access to medications, and then working slowly to build a continuum of care that stretches from prevention through acute care to treatment centers to recovery to community engagement. And it's a long road, and I know that a lot of you in the audience are on the front lines, so that probably looks pretty intimidating. But hopefully you've come away from this evening seeing that there is actually a road ahead, you know, and there is some hope on the horizon. And I want to thank you all for being with us this evening. And I want to thank our panelists for being amazing, brilliant, and filled with insight. So thank you, everybody.